part of the great interest in coming to an ACC scientific sessions is to get an idea of how what is presented here might change practice when you return from the meeting. So we're here to talk of several key sessions and the impact the findings may have. And I am with Dr. Hadley Wilson, who is an MD and interventional cardiologist at Carolina's Healthcare System's Sanger Heart and Vascular Institute. And Dr. Wilson also serves on the ACC's Board of Governors. What would you like to start with? Shall we try HOPE-3?
Absolutely. That was the first late-breaking trial that was presented yesterday, and I think it was very impactful because it was a practical trial. They followed the people practically every 6 months over 5 years, very similar to the way one might actually have to do in clinical practice.
Sure.
And these were regular patients. They weren't, particularly sick. In fact, they were relatively healthy with only one risk factor, which made them so-called intermediate risk. Mildly elevated blood pressure in one cohort, and then they just took all of them and treated those for high blood pressure with just a couple of combination therapy medications that are reasonable to take, and followed those. And then they treated the entire population with one statin at a relatively low dose. And then again, as I said, followed these over mean follow-up greater than 5 years, and found that the group that was most benefited were those that had mildly elevated blood pressure, and then they were all benefited by the treatment with the combination therapy for that. But they were also, in addition, greatly benefited by the addition of a statin, regardless of what their baseline cholesterol level was. So, this was very impactful, and it's also something that points to real-world developments in the future. It certainly reaffirms the recently guidelines that were produced in 2013, the latest iteration of the guideline recommendations for cholesterol treatment. It certainly supports those. And then in addition, it looks towards the possibility of this so-called Polypill in the future, where we could have these three agents together for, again, this intermediate risk population, and let them take this over time and actually see improved outcomes and reduction in heart attack, stroke, death, and other outcomes.
Because one of the problems with adherence is people may have multiple drugs that they're on, and it's just really tough to get all of them taken at the same time. So in this case, a polypill might really be helpful.
Absolutely. To have that together so that, that's one less pill, because it's a combination pill. It doesn't necessarily mean there's going to be any large horse pill. It could be something that would still be a reasonable size, but also it could be something that cost benefit could be proven over time too, in the fact that instead of buying three medications, you're buying one. They're put together, and then even over time, if we see these reduction in these cardiovascular problems, heart attack, stroke, and death, would be of great cost benefit to population health and to society.
And so the take-home message here for HOPE?
There is hope, and that is that more studies in this area looking at these medications for both low to high or mildly elevated blood pressure, and also those that have elevated cholesterol, that they can benefit from this long-term therapy.
Now, we also talked about GAUSS-2, GAUSS-3. Where are we with the GAUSS trials?
So the GAUSS trial is looking at the agents that, for those who are so-called statin intolerant, and these are the people that have muscle aches and other side effects, muscle aches being in almost 15 to 20% reporting. Right. Of people that are taking the statins. So there were a couple things that came from GAUSS-3. I think the highlights were that when these people were subjected to retrial in a double-blinded fashion, that if they had side effects with one statin, they often had side effects with another statin, and that was significantly more than on a placebo. So it's a real world problem. And then secondly, and maybe more importantly, is that when they were treated with these new agents that are now out as the result of GAUSS-1, yes, the PCSK9 agents, that they had significant reduction in their LDL and total cholesterol compared to those who are treated with the standard agents, the ezetimibe and so forth that's out there now. So, very positive that, this is a real world problem and this is a real world solution with the new PCSK9 agents to treat these population of patients who cannot take statins, and they can be treated very effectively.
Now, we had some major STEMI late breakers.
Yes, we did. Yeah, there were 3 STEMI late breakers today, and as opposed to what I was saying positively about these first 2 trials, all of these basically reaffirmed current clinical practice. And so that's good, but it's also a little disappointing that we didn't have further improvement. And the basic things that were presented were whether or not stent implantation delayed at the time of heart attack might actually benefit a patient if they had that broken up into 2 procedures, one later on when the patient was more stable and perhaps they would have better outcomes, and that was shown not to be the case. So that reaffirmed that the current sort of door to balloon time type pattern of trying to get the patient in there quickly, open the artery and put a stent in is actually again reaffirmed.
So efficiency works.
Efficiency works, and the way we're currently practicing this, at least for this particular part of STEMI therapy, is best for now.
What was the other disappointment?
The other was IV beta blockers, which have been around for 20 or 30 years prior to heart attack treatment, really showed no benefit, and that was very interesting. So even before the time that we were having door to balloon and opening up arteries and putting stents in, we've been using IV beta blockers in these acute heart attack patients. And this study basically said there was no benefit in terms of big factors like heart attack, repeat heart attack, and heart failure and mortality. There was some nod that it could prevent some of these more malignant arrhythmias, but in terms of total outcome, there was no difference. So again, it was saying that routine use of IV beta blockers for heart attacks in the early stages, at least for now, again, is not really additionally beneficial over what we're standardly doing.
Right. And the third disappointment? It was a tough morning.
The third trial that was of some disappointment, or at least not improvement, with acute myocardial infarction care was the another European trial where they looked at whether or not after opening an artery you could actually condition the artery or the heart, where those people might actually have improvement again in outcomes and reduced heart failure after a heart attack.
Is preconditioning?
Or postconditioning is actually, is what it's called, postconditioning. And basically it didn't show any change or any benefit in any of the major factors compared to the way we're, again, treating people with a standard door to balloon, opening the artery and putting a stent in.
So have you enjoyed the meeting?
I have enjoyed the meeting. I mean, there have been some positives and there have been some others that are, say, neutral or no additional benefit. But, again, that's always, that's the way of science and medicine, to just reaffirm, what we're doing, and that we're trying to slowly move ahead with progress and evolution of care.
And we have a variety of coverage from this particular meeting. I love coming here and the other meetings because you get to learn some different things. And we're going to have it in CardioSource World News, a separate issue for this meeting. And you will find that at CardioSource World News and CardioSource World News Interventions, where I'm Executive Editor Rick McGuire.